essentially, this is a very personal thing. Brace yourself, because in the next 15 minutes, I'm going to tell you 4 different, highly effective, non-surgical, non-medical ways to treat pain. And if you are interested in more details, just click on the QR codes, and you can get all the information that I can't tell you right now. Well, how did this all start? Because this started with at the end of my first pregnancy, when I started getting severe, almost incapacitating low back pain. And I didn't have anything wrong with my spine. I didn't have anything with my intra-abdominal things. And therefore, my pain was called non-specific. And in fact, in 90% of all cases, the low back pain is called non-specific. Why is it called non-specific? Well, because the joints that are causing the pain cannot be seen with medical imaging. Essentially, they are the sacroiliac joints. And it took me several years to discover that it was my sacroiliac joints that were involved. Now, why would these joints be such a common and frequent source of pain? Well, if you look at these 2 bones, the iliac bones, you'll notice that they're part of the pelvis. You sit on your sits bones here, and then your iliac bones are here. And your iliac bones are the ones that are the main source of pain. Now, why? Because the weight of your whole upper body rests on these bones and tends to push them away from the sacrum. So the sacroiliac joint is under a lot of strain. And now, if you look at the ligaments that hold these joints, if you look at the ligaments that hold a hip joint, you'll notice that there aren't that many ligaments. There's a huge number of ligaments holding the sacroiliac joints in front and in back. Why? Because that's the joint that has most strain in the whole body. If you look at that joint, you'll notice that there are even ligaments inside the joint. Now, there's 2 parts of that joint. There's the upper part that has ligaments, and then the L-shaped part. And you'll notice how full of bumps and hollows it is. That's why it can't be seen with medical imaging. The bumps and hollows mean that you can't see if these joints are well aligned or even whether they're in place. So let me talk a little bit about the ligaments, okay? The ligaments attach on both bones that form a joint, and they're made up of collagen. So they're collagen girdles that stabilize the joints. Now, these ligaments are full of nerves, and if these ligaments are overstretched, the nerves are going to be overstretched, and they are going to complain and send pain signals to the brain. The other thing you'll notice about ligaments is that they're gray, they're white, they're not red. They don't have blood vessels. Fortunately, they attach on the covering of the bones, which is loaded with blood vessels. Now, how do you heal after an injury? If you have an injury, you get inflammation. You get all red where you're injured. And that starts the growth of new blood vessels. And the blood vessels bring repair cells to the injured area. And the repair cells deposit collagen, scar tissue. But if you don't have blood vessels in an area, you can't start these new blood vessels to grow where you're injured. And so you can't repair yourself. And because there was no repair, I suffered from pain for 37 years. And that pain was at times incapacitating. So I was at a meeting with a friend of mine who's a sports medicine therapist. And I said, oh, my sacroiliac joints are killing me. And he says, come and see me. I'll do prolotherapy on you. I said, prolo what? And he said, well, if I do prolotherapy, I'm going to inject an irritant where your ligaments attach on the covering of the bone. And the covering of the bone is loaded with blood vessels because they're just over the bone marrow, and the bone marrow makes all your blood cells. And so if you want to have blood cells inside your blood vessels, you'd better go get them in the bone marrow. So the covering of the bone is loaded with blood vessels, and that will start the growth of new blood vessels into your ligaments, and it will start the repair process. And that can be used for anything that doesn't have a good blood supply in the body, like your joints, your ligaments, your tendons. And I started to do prolotherapy, and it was highly effective and relieving pain in all of these structures. Then I did a research project on rotator cuff tendinopathy, problems with the shoulder, and I've proved that prolotherapy was twice as effective in relieving the pain and the disability from the shoulder injury than was prolotherapy. But unfortunately, you can't have, then was physiotherapy. Unfortunately, you can't have prolotherapy all the time. You get it maybe once a month. But sometimes you get low back pain in spite of having prolotherapy, or because you haven't had it. And if these joints can't be seen, it may be they can be felt. And I'd like you to listen to what I've developed to feel the sacroiliac joints. You're feeling for the sacroiliac joints, you're feeling these bulges on the bone called the posterior superior iliac spines. When one of them is higher than the other, it means that the bone has tilted forward. If the painful one is lower than the other, it means the bone is tilted backward. So, essentially, to find out where your sacroiliac joints are, you just slide your fingers up your buttocks and you hit these little bones. And can you see how my fingers are going up over these little bony obstacles? This is how you find the level of your sacroiliac joints. Now, if one of these fingers, instead of being level, is higher up, then you know that your joint is displaced forward. You see, if these are the bones that you're looking at, the one that's going to be higher up shows that the bone is displaced forward. Now, if it's displaced forward, the way to fix it is to push it backwards. In order to push it backwards, you're going to use your thigh. Watch what I'm doing. This is how you're going to replace a forwardly displaced sacroiliac joint. You put your right foot on the floor, because this is the right joint, and you lean forward hard on it like this. And meanwhile, you push your left knee backwards to stabilize the other joint. And you hold this position for 2 solid minutes. Now, supposing the joint is displaced backwards. If this finger is lower, like so, it means the joint is displaced backwards. If it's displaced backwards, you see, if it's lower, it's displaced backwards. If it's displaced backward, you have to pull it forward. Now, to pull it forward, what you do is you're going to put your knee on the floor, and then you'll put the other foot forward, and then you're going to lean forward and move that knee as far back as you can as far back as you can, because what you're trying to do is you're trying to pull this bone forward. If you want to pull it forward, you have to feel a real pull in your groin area. If you do that, then hold it for 2 solid minutes. If you hold it for 2 solid minutes, that'll give the bone a chance to move in the direction it should. Now, I did a test on 62 people. I did a randomized controlled study to see if this exercise would help relieve low back pain. And it provided immediate low back pain relief to 90% of those with displaced sacroiliac joints. Immediate relief in 2 minutes. Now, I was a member of the American Association of Orthopedic Medicine because prolotherapy is orthopedic medicine. And one day there was a one-day seminar with Dr. John Liftoft. And this physician from New Zealand said that you could remove pain by just injecting around nerves with 5% dextrose. I thought, sugar to remove pain? Come on. And so at the end of his seminar, and this is what he was telling us, he said that, say you prick your finger, you have these very small neurons, C fibers, and slightly larger myelinated fibers, the A delta type, that have a receptor called TRPV1 or the capsaicin receptor. And that receptor will open up if there's an injury. Say you prick your finger, that TRPV1 receptor opens up and allows sodium ions and calcium ions to get into the nerve. That depolarizes the nerve, sends a pain signal all the way along the nerve, right into the spinal cord. And there, a second order neuron is activated and sends a pain signal to the third order neurons in your cortex. And all the medications that are dealing with pain, like opiates, antidepressants, anticonvulsants, all of these work on these 2 areas. But dextrose, so he said, sugar, works on these nerves. I was not convinced until the end of his talk, when 5 people with severe chronic pain came up the stage. He said, he called, how many people here have severe chronic pain? 5 people put up their hand, went up on the stage, received these dextrose injections to the nerves. Like one person had migraine headaches, and another person had severe pain in the neck, another one in the back, another one had knee pain, another one had peripheral neuropathy pain. And he injected the neurons that supplied these areas with 5% dextrose, and presto, their pain was gone, even before the needle was out of the skin. And so I was amazed, and I started doing that in my practice. So I started injecting 5% dextrose around nerves, but then I had a lot of diabetic people with peripheral neuropathy. And I was thinking, oh my gosh, if I'm injecting them with dextrose and these guys are diabetic, I may be actually making them worse. And so instead of dextrose, I started using mannitol, 5% mannitol, so that I wouldn't be supplying these guys, which were diabetic, with sugar. And the 5% mannitol around nerves worked just as well as the dextrose. But a whole bunch of people don't like to be injected. And so I thought, well, what else can I do? And there was a pharmacist who was there observing me because I had a very high success rate in removing pain. And she said, well, why don't we make it into a cream? And so we decided to make a 30% mannitol cream. And so and then I started giving this cream to my patients, and they were really happy and they wanted more and more of that cream. And so I thought, well, maybe I should test to see how well this cream works. And if it works on the TRPV1 receptor, the capsaicin receptor. So I put some capsaicin, some hot pepper cream on their upper lips. I put a tape to separate the upper lips, and then I put some hot pepper cream on their upper lip. And then when the burning reached 8 out of 10, I removed the capsaicin cream, and I was given a pink Q-tip for the right, a blue Q-tip for the left. I didn't know what I was putting on, but one of the Q-tips contained the base cream, and the other Q-tip contained the mannitol inside the base cream. And so I applied this, and then every minute we asked them how much burning is on the right, how much burning. They had a little graph that they had to fill out and to put a mark where the burning was on the right and on the left. And essentially, on the mannitol side, the pain improved much better and much more quickly than on the base cream side. And so essentially, the probability at the end of 10 minutes that the two creams were the same was less than 1 in 1,000. So I knew that mannitol shuts down the pain receptor, the TRPV1, the capsaicin receptor. And then I gave it to my patients. I gave them little 50-gram containers of cream. And I had patients with all kinds of pain, because in the last 10 years of my practice, I just treated severe chronic pain. And so I gave them containers of this cream under condition that they fill out a questionnaire. And the questionnaire had essentially said, how much, what the date, the time, how much pain they had from 0 to 10 before they put on the cream, how much pain 30 minutes after they put on the cream, how long it took for them to get better, and how long the pain relief lasted. Well, I can tell you that the average pain relief was 53%. Okay, it wasn't 100%. But then you have to remember that narcotics have a 36% pain relief. And NSAIDs, Advil, Aleve, aspirin, naproxen, Voltaren, have a 23% pain relief, and Tylenol has a 13% pain relief. So 53% pain relief is not bad. Now, which areas of the body had better pain relief? Where the areas where the nerves were closest to the skin surface, the lateral femoral cutaneous nerve of the thigh, the nerves of the legs and of the toes, the nerves of the fingers and of the hands. They had a better than 60% pain relief, right up to almost 80% pain relief. Now, the average pain relief for the neck and the arms and the feet was, and the back, was between 50 and 60%. And the head, like for headaches, pain in the shoulders, pain in the elbows, the palms of the hands and the ankles, that pain relief was only between 40 and 48%. But the average duration, I couldn't do an average duration because unfortunately, I had some people who put the cream on once and their pain was gone forever. You can't divide by infinity. But the median duration was 4 hours, and the average time to relief was 17 minutes. So we decided to commercialize this cream. And if you go to qrcream.com, you'll find that all about that information. And I've got detailed information if you look under the effectiveness of the cream on every single number of patients treated and so on. And you can also click on this QR code and find out all about it. And that's the end of my presentation. Any questions? Everybody's being so silent. I wonder if you guys can ask questions.
Hello. Thank you, Ellen, for this great presentation.
I do have a question.
Yes.
Hi. Yeah, so have you got like any results of the combination of like traditional kind of treatments in combination with the sorry, I have pneumonia lately, so my voice is a little bit changed. Yeah, so what is the results of combination of like regular physical therapy with like conventional treatment with what you just presented to us? Sorry.
Yes, I did a randomized study where I compared physical therapy with prolotherapy injections of 25% dextrose in the shoulder. And the QR code for that study is in my slide presentation. I hope you're going to get a copy of my slide presentation, because that way you'll see exactly what was done and so on.
Well, I'm sorry. I was, I don't know, I was kicked out of Zoom and I couldn't hear you from the first part. I'm sorry.
Okay, well, I did a randomized placebo-controlled, well, no, prolotherapy, a physiotherapy controlled study where people either received the injections or they got physiotherapy, and the dextrose injections, or they got physiotherapy. And the people who received the prolotherapy were where it had a pain relief that was twice as high and a functional result that was twice as good as the people who got physiotherapy. So this is why I think prolotherapy, the rebuilding of ligaments and tendons, is much better than physiotherapy, which merely trains the muscles of the body to control the joints or the defective ligaments and tendons. So I think rebuilding is much better than just palliating. In the same way that if you want to control pain and you use this sugar solution or mannitol 5% solution around nerves, you've got a much better results than you do with narcotics. And the reason you get a better result is that you're addressing exactly the source of the pain, and you're calming down the nerves at the source of the pain. By the way, I also found out that if these people would give me these sheets with, at this time I took the cream, at this time I took the cream. They gave me these sheets, and when they did that, I could see that their pain levels would go down as time went on. So I know that this mannitol containing cream actually brings the pain level down. The continued use of the cream makes it less and less needed. So instead of being narcotics where the continued use of it means that you need more, this mannitol containing cream actually means that with continued use, you need less. So that, because you're calming down the nerves that are the source of the pain. It's treating the source of the pain that's most important.
Oh, that's great. And there is like a specific age, or there are people that benefit the most from this treatment, or it's irrespective of age and mechanism of injury?
It's irrespective of age and mechanism of injury. It depends on the treatment, because I presented 4 treatments. Older people, for instance, don't rebuild their ligaments and their tendons. They don't heal as well as young people. So prolotherapy doesn't work as well in older people, but it does work even in older people. And you can supplement it with growth hormone or a little bit of testosterone, and that will increase the healing ability that old people have when they get prolotherapy. The dextrose injections work for everybody. The mannitol cream works for everybody. In fact, I used it on my grandchildren when they had mosquito bites and they were scratching. I would put the cream on and they immediately stopped scratching, because of course the mannitol was acting on the nerves directly under the skin, and those nerves were right there, and that's where the mannitol did its work. So it depends on where the pain is. If your pain is too deep, the mannitol cream can't work, but the perineural injections of 5% dextrose or 5% mannitol work exceedingly well. So and that works for everything. Like if you have a migraine headache, the nerves that are involved are here. These are branches of the trigeminal nerve, right? Supratrochlear, supraorbital, lacrimal, and these branches of the trigeminal nerve, if you put the cream there, it takes away your migraine. It's because the nerves are very close to the surface of the skin. So it depends on where where the nerves are and what you're using as a pain relieving technique. Thank you very much. Thank you very much, Christina, for asking questions. I like people who ask questions.
I'm in geriatrics, so pain is something that is very common for my population. So this is very interesting.
Well, essentially, you should read the article that I wrote. I wrote 2 articles in the journal Curious, Cureus, under my name. Look it up. I've got one about how what I just told you, the story I just told you, which is why I started dealing with severe chronic pain. And the second article is essentially how to fix low back pain. And you can fix low back pain in anybody, Christina. And there's a 17-minute video, which is also on YouTube, that's part of that article, that explains exactly how to examine patients to discover the levels of their PSISs. And what I do is I use a ruler with a level on it that I've got here. And that ruler, you see, has a level, and I can tell the level of the sacroiliac joints by marking the sides of the PSISs and seeing, and then seeing whether they're level or not level. And if they're not level, then you know how to fix it by using your thigh to push the bone back if it's too far forward, or pulling on your thigh, which means you're using your sartorius and your rectus femoris to pull on the ASIS of the iliac bone and to pull it back into position. And it works in 90% of all the people I've tried, so who have a displaced sacroiliac joint. And 90% of all people with severe low back pain have displaced sacroiliac joints. And it just amazes me that nobody has figured out that all you need is a level and your 2 fingers to examine where those PSISs are. It just boggles my mind. Because it's so effective, and I hope you will start using it with your older people. And if you look at the 17-minute video, you'll see how to replace it in somebody, for instance, who can't assume that position or who can't do the exercise. There are many, many ways of using the thigh to fix a joint. And you can do it yourself with a patient on the examining room. So
Thank you very much. Thank you very much.